This is EHJ Today at the Cardiology Update in Davos, Switzerland, 2017. I'm Tom Lüscher, Editor-in-Chief of the European Heart Journal, and I'm talking to Professor Alec Vahanian from Paris, who is a good friend, Associate Editor of the European Heart Journal, and an expert in valvular heart disease. Welcome, Alec. So we're going to discuss the topic mitral regurgitation. When is it too late to intervene? Mitral regurgitation for quite some time is asymptomatic, and of course that's a dangerous period, and you may end up with a patient with very low ejection fraction, and then becomes very difficult. So how should we follow up these patients?
Well, I think there are two different mitral regurg, and here you allude mostly to the primary, the organic mitral regurgitation, where you have the prolapse, let's say degenerative, patient is asymptomatic, and you follow up. Well, now we have some evidence, and we wrote guideline, ESC guideline in 2012, that the latest US colleagues wrote in 2014. Grossly, the follow-up is clinical. Yeah. Well, if patient becomes symptomatic, very easy. We probably have to do more exercise testing. I think that's important because it's a continuous way of becoming symptomatic, so it's important.
So patients get used to the fact that they're not, then they assign it to age rather than to the mitral valve disease.
I think, well, if you can perform easily stress test, I don't mean echo, but stress test, that's quite important. And then echo. And then echo, and as you said this morning, I think during the presentation, there is no magic number. You have to integrate what is the operative risk of the patient, because here we're considering surgery first step. What is the operative risk? If the patient has very low risk, you are prone to intervene. You have to consider also the skills of the surgical team to repair the valve, because in most cases it can be repaired, that's very important. And then the parameters. So if you have an overt LV dysfunction, that is LV ejection fraction, which is not good, but that's what we have, below 60%, you should go definitely. Then some threshold were fixed for the end systolic diameter, that's important. It's prone for error, so you have to repeat measurements, that's good. And then you have the pulmonary pressure, which is important. At rest, a couple of data probably has to be confirmed on pulmonary systolic pressure on exercise. If you have AFib, also it's an incentive to operate. So grossly, if you have these signals, you are definitely to operate.
I have a question related to the ejection fraction. Don't we overestimate the ejection fraction in these patients because resistance is so low, and when they have 50, they may in fact have 30.
Yeah, no, I do agree with you. It's imperfect, but it's what is done in practice, and it is a parameter used in the longitudinal study. So we have to take into account the threshold for normality is not 50, it's 60. So the Mayo Clinic, mostly the Mayo group with Enrique Serrano, showed that below 60, you are really entering into trouble because there is usually a drop after surgery, a small drop, but a drop. So below 60, it's not normal, you should do something. But I agree with you, we have to investigate more the strain and other parameters, but I think that as of now, there are not sufficient data to encourage intervention only on strain.
Right. So let's say the patient has a slight decrease in ejection fraction, you intervene, that is relatively easy if he's symptomatic in particular, but then you get a patient that has not been followed up by anybody, now has severe dyspnea, comes to you, has an ejection fraction of 30, large ventricle, AFib, what do you do then? Yeah,
well, that's a difficult group, and as you said, we choose in the guideline committee 30 as a threshold, just like US colleagues. The rationale behind this magic number of 30, I don't know, but we choose.
Eminent space.
Yeah, okay, that's it. So I think if the patient is a good candidate for valve repair, because the valve is okay, the team is okay, everything is okay, probably make a try. If he's not a good candidate for valve repair, here well, in the previous guideline, we wrote medical therapy, extended heart failure therapy, etc. Now I think with the data we have from MitraClip, I think that probably something which can be proposed to the patient if he's amenable to this therapy, but I really do think that this patient require a very, very extensive discussion within the heart team.
So the operative risk is an important consideration.
Important consideration, so discuss MitraClip, discuss also the valve repair. If the valve repair is doable, I think we should probably go for that. But if it's not, really, I would encourage discussing the MitraClip, because in experiment, in people with good experience like Francesco and others, you have very good results. You can provide, let's say, a satisfactory result, and the team discuss according to the individual patient.
Is there, as we then announced in the title, is there a point of no return where you cannot do either MitraClip or surgery, or are you gonna try MitraClip anyway, even if the guy has 20% ejection fraction? What are your thoughts there?
I must say that in primary mitral regurg, we don't have many data in the registry, because most patients have secondary in the registry, so it's a small proportion, and we're not going to have data because most trial, the COAP trial, still enrolling, Reshape still enrolling, and Cocorico, the French one, which is finished now, completed, Mitra FR, concentrated, focused on secondary MR. So we won't get the answer.
So when is the French trial presented?
The French trial will be presented most likely around mid, hopefully during the ESC Congress in 2018.
So you have to wait.
You have to wait, yes, for this one. But I mean, so for the patient you described, if the guy is really 15%, I think it's over. Yes. If the guy is, 20 plus, you can probably discuss. But there is no magic number. It is the heart team looking at the patient. Right. If the patient has many comorbidity, probably you let him go or do a MitraClip. If he doesn't have many comorbidity, it's a matter of discussion, because it also depends what is the transplant policy, how many transplants you do, or LVAT in your center. So this should be discussed. It's a very difficult group of patients, but unfortunately we won't get a solid evidence-based answer.
So we need to really pick up mitral insufficiency or regurgitation early on. Definitely. For the benefit of the patient.
But I'm a little bit afraid of the reality. Yes. And we'll hopefully submit to the editor of European Heart Journal in the coming months a survey which was done among GPs.
In France?
No, in Europe.
In Europe, yeah.
ESC runs this thing. GPs, cardiologists, cardiac surgeons, about the way they manage patients with mitral regurg, and you'll have some surprise. We'll have some surprise.
Good. We're looking forward to see the paper and read it in the future. Thank you very much, Alec.
Thank you, Tom.